our student webinar. We're already at number 46. If you are joining us for the first time, I'm glad you're here. And if you have come to several of our webinars, then you know with our student webinars, we have questions that come in from the students, and then we do some extra teaching on those. All of our students, heads up, as well as club members, this will be in the CCO club afterwards. Those of you who are joining us on Facebook and YouTube and LinkedIn Live, it'll be up for a little while and then it'll be pulled. So you can always go and join the CCO club and you can watch this again later. That all being said, we've got a great topic we're talking about tonight. So if you didn't know, for the new year, 2020, we've got some changes in the CPT manual under complex repairs. And we had gotten a question on how to code a complex repair. When you are working through CPT and you're doing your integumentary training, definitely this is an area that you either get it at first or you don't, but we try to make it as easy as possible for it to click for you. Three types of repairs that are going to happen. You're going to have a simple repair, an intermediate repair, and a complex repair. Now, we're only going to talk about a complex repair tonight. We've done a lot of training, and there's also stuff in the textbooks and things that are going to help you, examples as well of simple, intermediate, and complex. But the question that had come in had kind of rode up against the changes for 2020 in the CPT manual, in the guidelines. And so I want to clarify that for you. It's a pretty simple change, but it's really helpful if you understand, like I'm always saying, the disease process. If you understand the type of wounds that would necessitate a complex repair versus a simple or intermediate. And we're going to look at some documentation to be able to pull out or abstract information that's going to give you a heads up. Hey, this is going to be a complex repair. Some key phrases, some key things that you can abstract so that you don't have to, dwell over it. Another thing I wanted to give you a heads up for our students, especially if you're new to coding, there is a interesting little guideline with CPT that a lot of new students struggle with. When you go to code for a repair, there will be a code for the whatever you're doing. Like say you're removing something, a lesion or something, and then there will be a code for a repair. So it's not always like a traumatic wound care. But what trips up the new coders and might have tripped you up if you're thinking back about when you were taking your training, if it is a complex repair, you're going to code that CPT code before the removal of whatever you're removing. Say we've got a lesion that we're removing. And so keep that in mind. CPT gets sequenced from complexity, not the chronological timeline of the events. Whatever is more complex gets coded first. And so, of course, if you do a complex repair, let's say we remove a lesion or a squamous cell carcinoma right here on the face, on the nose, that's going to be a difficult repair because they'll take a big giant chunk. They'll probably do some type of a flap or something like that. So the repair gets coded first. It was a lot more trouble than just whacking off the lesion. Okay, so that's a little heads up. We're not really going to talk about that tonight, but because it's something associated, I just wanted to put that little tip out there for you so that you could remember it. Maybe jot it down in your notebook. We like to have you have a little notebook next to you when you're watching any of the lectures or the videos or webinars that we do, so that if I say something or one of our instructors say something, and you think, oh, I need to do more research on that. Or sometimes I'll tell you, go do more research on this on your own. Then just jot it down, or a phrase or a term you're not familiar with, you can go look it up. So now we're going to talk about what do we need to know for complex repair with a specific understanding of the new guideline in 2020. Now, this is a little expert picture. So our Tiffany, who works with us creating our blitz and changing all and updating everything for the new blitz, brought this one to my attention the other day, and then she sent me this picture. And so this is kind of like, or this is exactly like what it would look like when you're going to blitz or bubble and highlight, do the bat technique with your CPT manual. And we have training on that, just individually doing that. Maybe you're sitting for a new certification and you need to get your CPT manual ready for testing, or you just want to make this information pop off the page for you so that you can code to a higher specificity. So the little area in your CPT manual 2020 for complex repair, highlight complex repair, make sure it's different between intermediate and simple repair. And then it tells you, what is required for a complex repair code. And this is pertinent, requires at least one of the following. This is what changed for 2020. Now, what I did was, of course, on this, the picture didn't come through really, really good on that being highlighted in yellow. However, I broke this up for you. So this is what it looks like in your manual. This is how you would highlight it. Okay. Now we're going to break that all up and talk about what each of those things constitute, or examples of those. So we need at least one of the following for it to be considered a complex repair. So that has to be documented. Now let's go ahead and look at those on an individual basis. So, exposure of the bone. Now, with exposure of the bone, that means we could have cartilage, tendon, or a neurovascular structure. But look, the key is we need a named neurovascular structure. Okay, that's important. It can't just state. We got to know the name of what that is. Okay, so that's our first bullet, exposure to the bone. If we have exposure to the bone, then it's going to be a complex repair, which that is pretty self-explanatory, right? In the past, we've always said, well, we got multiple layers that we have to go through to do the repair. And if we're all the way down to the bone, that is definitely going to be complex. One of the things that you have to consider is that when they're doing that repair, they have to really irrigate a lot and debride if it's to the bone, if this is a traumatic wound, because we're more likely to have infection. Also, when you have something that goes down to the bone, I'm always talking about how they do the closures, and we'll talk about that, So let's say down here is to the bone, and you can't just close it like this at the top. You have to do layered sutures, because what happens when you close and make a pocket of any type of a wound, inside that pocket, it's a warm, moist, dark spot, right? And what does our body do? It starts sending white blood cells and blood components to clean that up and protect itself. Well, it fills up with fluid. So we got a warm, dark, moist spot that is, going to breed bad things. So they will close it in layers. So they'll close this section, and then they'll close that, and then they'll close this on the top, with different types of stitches, so that that tissue is all together. And when it's all together, it'll heal together. Otherwise, they've got to leave it open and let it heal from the inside out, and that involves packing and stuff like that. So again, exposure of bone, cartilage, tendon, etc. The second thing that could be in your documentation is debridement of the wound edges. Now, when we talk about debridement, when you have a wound that is like a traumatic laceration or an avulsion, then of course we're going to have jagged edges. An avulsion would be like this. It's like someone took a spoon and scooped it out. Okay, you're going to have irregular edges, irregular on the inside. Now, in a laceration would be, more of a straight, but it's still going to be not smooth like having an incision. Okay, which is, with a sharp instrument, a nice, clean, straight line. Traumatic lacerations are not going to have clean margins or clean edges. So sometimes that you'll be able to tell that there isn't good vascularization anymore to those edges, and they're already starting to die, or the tissue is shredded too thin. uh, and so when you go to pull those edges together, then we're not going to have a nice, clean, smooth edge, a border. And therefore sometimes they'll go ahead and snip that off. One, because of vascularization, one, because they want to make their suture line as smooth as possible for good healing, as well as scar tissue that builds up. If you go and look at repairs that are done, I really like Dr. Sandra Lee for this, because you'll see her pull those margins together when she removes maybe a cyst or even a lipoma, especially if it's a large area. You have to, you see what she does. She did Yeah, she's a dermatologist, but she also had worked with plastic surgeons too, so she, you want that to be pulled together smooth, because if you pull this together, right, it's going to pucker and it's not going to give you, but if you put them together like this, you're going to have a nice line. And a big giant lipoma, whether it's on the back and the shoulder, when you take out something that has been a mass, okay, you're going to have an indention, a pucker there, right? And so sometimes you have to debride those areas, cut away and make that smooth and pull it snug together. But debridement of a wound edge for a traumatic laceration or an avulsion, again, is going to constitute a complex repair. Extensive undermining. Now, what does that mean? That is going to be a little bit of math here. We're going to have a distance greater or equal to the maximum width of the defect. Now, whenever you do anything like this, wound repairs, you're going to see a lot of measurements. That's part of standard documentation. You're going to see how many sutures were put in, especially on the top. They won't, as well as how many sutures are used underneath as we close the layers. When we do this, maybe they do 3 sutures underneath to do that. Now, when we look at something and the distance is greater or the same as the width of the defect. So let's just say, for example, we have an, I don't know if I can get my hands like that. We have a wound that's this size. Okay. Now let's make it like this size. And now let's do it on my hand. I don't like some of those symbols. Those are actually sign language symbols that aren't very appropriate. So let's say we have a laceration on my hand right here. Okay. Now, if the laceration goes from this knuckle down past my wrist, that would be the length. So if the distance, this length, is equal or maximum to the width of the defect, so from here to here. So let's say I've got a traumatic laceration from here to here, and it's laid open across my hand. Okay. So if that length, if the width and the length we have to compare that. Also, you can measure perpendicular to the closure along at least one entire edge of the defect. So perpendicular. Didn't know you were going to have some of these phrases when you were in school and they talked about, I don't ever need to know what perpendicular means. So again, that could constitute the need to classify it as a complex repair. Continuing on, extensive undermining. Let's see. Okay, I guess I copied that from the previous. Sorry about that. You got to see that twice. Let's move on to involvement of free margins. Now, when we talk about free margins, that is usually associated to an area that's very difficult to suture. So I like to talk about that vermilion border because if you're a female and wear lipstick, maybe you use a lip liner and you use the lip liner on the vermilion border. That is actually the area on the mouth, the outer ledge of the lip itself. Okay, and so if you have a suture, a repair that needs to be done here, and then that means the vermilion border will be involved. Also, the nostril rim. Your nostrils these are called nares, if you didn't know, your nares, your nostrils. And so if you get a laceration or a repair that needs to be done here, that takes more time and, you know, decision making and skill to get one here or here on the helical rim as well. So that will classify as complex. Placement of retention sutures. I'm going to give you an example of retention sutures. It's just going to be easier to show you than to verbally try to explain it. But retention sutures are sutures that have to be used to hold that area together. You know, we don't want to have to do sutures in an area that's flexible. So this would be your knuckles here. Anything that moves would be a really difficult area to suture. So I have a story. Imagine that. My daughter called me the other night and she said, I'm going to send you a picture. Her number 4, the kids were playing with their father's exercise bar, and it wasn't a bar like you put barbells on. It was one of those bars that you put up in the air and it's on the in the door frame, you know, and you do pull-ups and stuff. So they were trying to do that. And I guess it fell and it hit her on her foot and it hit this toe right here. And they thought she had amputated her toe. They said it was just looked like it was just barely hanging there. Uh, Ultimately, what it did is it took the flesh off to the bone. However, she's very, very tiny. So she's 1.5, you know, so you can imagine how tiny her little foot was. And that is a moving area. So ultimately they chose, because it um, didn't fracture the bone, which nobody understands how that it happened that it didn't fracture. They chose to not suture because that is going to be really hard to work with. And again, you know, we have to be careful. Retention sutures are sometimes used to hold that places together that move a lot. So let's talk about some verbiage here and explain what uh, uh, types of wounds that you might see that would constitute complex repair. I think that that it would give you a heads up so that you can say, oh, okay, I understand. This is going to be an X, so therefore it's going, you know, if you say X, Y, and Z, and X is going to pretty much always be a complex repair. So when you have a wound and you they're telling you here you've got a disruption of normal structure. Okay, so again, like I said, we've got a laceration here. There's not a whole lot of meat on the top of your hand, right? And so whenever you have a laceration, if it was that long, a traumatic laceration, a lot of really important anatomy is in there. So you can see, I'm looking to make sure it's showing up well. You know, your tendons, your ligaments are right there holding those little bones together, as well as you've got a lot of movement and turgor on the skin itself, but the nerves, you know. So again, if you have specific types of injury, then you're going to uh, it'll be necessary to spend more time and involvement trying to get a repair done. So, what type of wound do we want to look at? These could be things like from traumatic injuries, and traumatic means that it wasn't done on purpose for a procedure. Okay. Uh, Thus, if we were removing a squamous cell carcinoma from the face and part of the nose was included here, you know, that's not a traumatic injury. But if I got hit in the face with a, you know, a softball and it's split right here, yeah, that's a traumatic injury. So abrasions are something that, you know, it just takes the hide off. Okay, so you usually have a pretty big area with an abrasion. An abrasion can actually end up being a little bit deeper than you might imagine, a little harder to stitch abrasions because they might have to just put a stitch here, 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 and here where it gaps a little bit. But also, a lot of times when you have an abrasion, you have a lot of area that needs to be uh, debrided and cleaned out, irrigated really well. Nothing worse than seeing somebody that's been in a bike wreck or a motorcycle wreck. They're going to have lots of abrasions on them. They road rash, right? Puncture wounds. Puncture wounds are difficult because they can go to the bone very easily, but you know, and they can take out some vessels and important structures on the way, but it can go straight to the bone, right? It might just be a little hole, but it goes deep. A crush injury. So I would a crush injury would be like something heavy falling on your foot. My father ended up having a backhoe shovel come down on his foot, and it broke his ankle and foot. He did construction work for a long time. So again, that would be an example of that. Burns absolutely can take complex repair. Gunshot wounds, and you know, one thing to have buckshot that's going to, if you have buckshot and it's in an area that is close, right, it's going to take out a massive hole. But if you have buckshot that's farther away, it's going to make a larger area. But a lot of gunshot wounds, you'll have an entry point and you'll have an exit point, usually. Not, well, not always if you don't have an exit point, but that's what you look for, is that the entry wound and if there's an exit wound. And the thing about the entry wound could be very small. It could be, you know, the size of the diameter of the end of your finger. Uh, but the fact is once the bullet impacts, then it opens up, right? So the end of the bullet opens up like this and doesn't always fragment, but it has jagged edges. And so it hits, it'll go in, and then it opens up, and then it does this on the way out. So again, you have a little hole that opens up and flowers out, and it takes everything out on its way. So through the body. So the exit wound, the entry wound could be tiny, but the exit wound could be this, like this. Okay. So gunshot wounds would have repairs, entry and exit wound. And of course, they're going to be trying to take care of everything on the inside. Animal bite. The thing about animals, especially dogs. Now, cats will do this, you know, multiple bites like this. Dogs will hold on and shake their heads, right? And so, of course, you're going to have a lot of tissue and damage like that. It's not always just the puncture wounds, but it would be a puncture wound. And of course, surgery. Now, it's important to know that you can have etiologies, or so the cause. You'll want to know what that is in the documentation, and uh, depending on what the etiology is, you could have breakdown of tissue later, okay, and could cause the wound to degrade. Let's see, blood flow. Absolutely something that we have to be very cautious about. Like my granddaughter, they will have to keep an eye on that, because it just kind of took the hide off of that itty bitty little digit, that tiny, tiny little toe, and the bone and everything was intact, but the vascular system had been compromised because it took the skin. And so, again, keeping it clean, and deciding not to put sutures in, letting that stay open and heal from the inside out. Also, you can have ischemic breakdown of the skin, meaning we're not getting, vascularization. Perfusion, we have to look for that. If you could have problems, it's impaired, and it could be because of proximal arterial obstruction. So maybe your person has PAD. And if they have PAD, then they're not going to heal as well, especially on extremities. Vascular compression. Maybe they had to put a tourniquet to stop the bleeding on. And then tourniquets are not meant to be used and not taken off. What they'll do is they'll release them for a little bit and vascularize the extremity and then tighten them back up. Otherwise, you're going to lose the extremity. You could have also hematomas that build up and compress the vascularization of the area, as well as damage the nerves. Immobility, we've not able to move around, and you can have pressure points. Also, you have to remember that we have microvascularization. So as we get to the capillary area, we could have occlusions there. We could get a thrombosis. You can have vasculitis. Cholesterol crystals could build up as well. So knowing what a person's other maybe chronic conditions will, when they do wound repair, they'll take that all into consideration. I wanted to also let you know that in the resources slide, where I got the content from this, you'll be able to access that, and great reading. Really, really good reading that will build onto your skill set. Sometimes if you look at the surrounding information, like how vascularization affects wounds, right? Then it makes you better understand why they do what they do for a specific type of a wound, or the because of an etiology, maybe even what why they made a decision to not put a stitch or anything in my granddaughter's foot, because of several factors. Okay, so in addition, it's important to understand, when you're reading the documentation, the different type of sutures and repairs that are made. And these are going to be terms that'll be red flags for you. It's like, oh, okay, now I know it's going to be a complex repair because they use this type of a suture, or they did the undermining. But if you understand the different types of repairs tools, then again, that helps. When you see more than one type of suture being used, that when they make their stitches, heads up. That usually means they're doing layered sutures. Okay, so what are the sutures, stitches, and staples? They all have the same purpose. We're closing a wound. Okay, and it could be a wound or a surgical incision, but when I say wound, in my mind, I don't always just assume that it's traumatic. A surgical incision to me is still a wound in the skin. We've opened up the skin. So uh, forgive me if I just lump everything into a wound, and you think, oh, but that was, an open appendectomy. Well, yeah. Okay. So, but they created a wound, even though it was a surgical incision in my brain. Um, okay. But sutures, stitches, and staples are not the same thing. They're actually different. Sutures, we'll talk about them. They are what you're using to close the wound, all right? But stitches is actually what's done for surgical procedures for closing the wound with sutures. So when a person, it's not really synonymous in the medical field. It is for a layman, and they say, "Oh, look, I got stitches." Yes, you got stitches. But uh, the sutures is what we did to the patient. We stitched up the patient with sutures. So let's talk about the different types. We could use absorbable sutures. Back in the day, we used to call it cat gut, all the time. And that is actually, they'll still use that term. You notice it's on the list. Now, I may not pronounce these as properly as maybe somebody else would that uses them all the time, but it doesn't matter. You don't have to pronounce these. All you have to do is be able to recognize them. And the term poly, as you may know, is going to be your giveaway. And often when you see poly, P-O-L-Y or P-O-L-I, it is going to be an absorbable suture. So it will be a suture that's done inside the layers. Okay, so that's going to be a deep suture, and then the other we'll talk about the ones that are going to go on top. But poly is a term, is a prefix that you see a lot. So you've got polyglycic acid sutures and glycolic, excuse me, polyglycolic acid sutures. We got polygalactin 910. We've got catgut. We've got polyglycephalone 25, and let's see, polydioxone sutures. Okay, and again, I never say these in my head. Never. I just look at the word and go, okay, those are, and then I think to myself, cat gut. these are absorbable sutures. Okay, but they're not all cat gut. Non-absorbable sutures are sutures that need to be taken out. Okay, so the ones that they do inside, they're going to be absorbed into the body. That's why we're going to be able to close it up on the top. And non-absorbable sutures, you're going to see things like polypropylene sutures. That's one of the most common that I see in documentation. Nylon sutures, which they'll say polylamide or polyester. I don't see that very often. PVDF, silk and stainless steel sutures. And again, these types of sutures are used for specific reason. So if we are, let's say I have a wound on, my arm and it's to the bone, they're going to use, polyglycolic acid sutures underneath. And then on top, you'll see the polypropylene, where they just stitch that up. And again, they use nylon, polyester, silk, and stuff like that for other things, specific things. Stainless steel sutures, a lot of times you'll see those being done in types of things where they're pulling, doing things like facial and pulling bones together and stuff. Retention sutures, they'll use those sometimes on the face, and they are every the 5 to 7 days they'll take those out. A lot of times they'll leave the non-absorbable in for 14 days. Okay, but these are retention sutures to help hold the integumentary, not integumentary, the integ, the turgor of the skin. Let's say that. Let's see, you can do on on the neck, 7 days. On the scalp, it stays 10 days. On the trunk and upper extremities, 10 to 14 days. And on lower extremities, 14 to 21 days. And then under greater tension may have to be left in place longer. And again, retention sutures are to kind of hold everything in place. Sometimes they will use uh, non-absorbable sutures, like this to put everything together, and then they'll go through and put a retention suture in there too. Okay, it just depends what they have to do. And we've got pictures of that. So this is what they look like. This is the most common, those single interrupted closures. Now, why do they do that, you think? And again, feel free to comment while we're doing these webinars. Make comments to share with each other, and absolutely, when it goes up in the club, make sure, especially you share, say, yeah, I had these stitchers or something. But you'll see these most commonly done because what it does is it allows that if you pop a suture, one comes undone, it doesn't undo all of them, right? And again, it could happen that one of the sutures, will pop for whatever reason, and but integrity, I shouldn't have got that in my head, will stay together and keep the wound closed, right? And so that's why they do that. And you'll see them when they do those repairs, with the needles curved, and we got some pictures of that, and they hold it onto it with a forceps, they put it in, and then they have another tool, and then they wrap it and pull it through and then cut it. Okay, there's a special little way to do that they practice. And you can go out and see YouTube videos on how to do sutures. There's lots of training out there for providers to increase their skill set, so again, or just watch, like Dr. Sandra Lee does these most of the time as well. And every once in a while, though, they'll do this running stitch. Now, there'll be a specific reason why they do the running stitch. And what with that one, they just have to clip one in, and then they can pull it out in one long movement. Okay. And off the top of my head, I can't remember why they do this one versus the other, but I think it has to do with the location, what type of a wound they're dealing with. It would definitely be one that, probably doesn't have as much movement. I can't remember. But hey, great reason for you guys to let us know if you know why they do one versus the other. The this next one is a really unique one too. It's a cuticular running closure, and I think they do this type very often when they're wanting to not have a scar. So what that does is they are actually going in the subcu tissue, pulling it together so that it makes a nice smooth line, right? And letting the top heal on its own. Okay. And again, the geographic area on the body is going to tell what type of suture as well as what type of wound that the person has. This is probably for C, for this running closure that is sub-Q, it's probably not a very deep wound. Okay. And we just need to pull that the top layer together. And then when it heals, they'll just snip that one piece and just pull the rest out. Again, take some time. To better understand the different type of sutures that are done, because when you see them documented, that'll help you understand if it's a complex repair or not. Okay. Now, here is a difference between an incision and a laceration, the type of wound. This is important to understand because you're going to see it in the documentation. It has to do with being a nice straight line with and not jagged areas. That the only reason you would need to debride or cut that is if you're wanting to cut the end to you'll see them do that sometimes because it'll pucker on each end when they do the repair. But that type of a repair is a lot easier to do and incised versus a laceration because and so whatever hit this hand was very sharp, okay, and probably was not a like a bread knife. It has all the edges serrated. Nice sharp instrument did that one. Whereas a laceration, it still can be very, very straight, but you see the texture. See how it is not perfectly straight on those margins. Okay, and it is incised versus laceration is going to make a difference. Inside is going to be a pretty simple repair unless it's deep enough that they have to do layered closure, and they could, but you're not going to have that debridement and stuff probably. But this, of course, is going to absolutely, the tissue underneath has been compromised differently than the tissue under here. Okay. All right, now that vermilion border, we got into the vermilion border here because even though it's only slightly in the vermilion border, it got it. So what does that tell us? That is definitely can end up being a complex repair because it got the vermilion border. You have to be very, very careful. And these are, individual stitches in there. And I don't know for sure. But if you look real closely, okay, these are black and they want to use very, very thin thread so that they don't leave a scar. But see this white right here? That may have been one of those other sutures underneath to pull that together. So they would snip it and just pull it out. And then 3 stitches on top, these disconnected stitches. But keep in mind the comment that came from Dr. Lent here. What you're going to see in ERs, careful repair is necessary to ensure the best cosmetic result. And again, that's why you're going to end up constituting a complex repair too, is because we're just not whip stitching this together and closing the wound. We don't want to leave a significant scar. And so that's going to take more time and detail to be able to do that, and probably having to cut a little bit of the tissue to make sure we got a nice edge. So if we're doing a cosmetic results, it says even a 1 millimeter of a vermilion misalignment may be noticeable. So that's tiny. So again, when you're pulling that together, if you pull that together and it's off just a little bit, you're going to get a pucker, and then it'll heal that way and they'll have that pucker forever. Okay. So be very, very careful when you're looking at something that you think isn't. Why would that be a complex repair? We're just, 3 little stitches, but it hit the vermilion border. Okay. And that was on our list. Now we're going to talk about some examples. And actually, these, I believe, came from Coding Clinic. I actually got them from another article, which I did put that in the resources slide. But I'm pretty sure I recognize these as examples in Coding Clinic. And one of those resources. It might have been CPT Assistant or something like that, but it is notated there. Example 1. I can't remember if I did 3 or 4. So let me go through and normally I don't read things, but let me just read through here the highlights of what should pop up off the page for you. So 1, we want to know what the etiology, what was the external cause, what happened. So of course we have a 4-year-old. Now that is going to be significant, just like my granddaughter who was a little over 1. being younger could it ends up taking over a larger area. So a 1-inch wound on a 4-year-old versus me, I'm 51, is going to be significantly different. Okay, so then we fell on the edge of the pool, strikes the mandible, which is the jaw, and experienced or got a 3.5 centimeter serrated and curvilinear. So serrated, think of a serrated knife. That's your bread knife if you have knives. Serrated means it has scalloped type edges, right? And then curvilinear means that it's linear and it has a curve to it. So this is not going to be something easily to repair. That should be red flags. Full thickness laceration, ding, 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 full thickness. Okay, so make sure you jot that down if you don't understand what full thickness means. That means it was deeper and we're on the chin. Okay, so mandible, we lacerated the chin. The pediatrician elects to widely excise the serrated skin margins. Okay, so we have some excision going on because the edges are serrated. So they're like this, all right? And we don't want to suture this. We want to suture this. So he's going to go ahead and take off all those edges. So I think of that as debriding, but he's going to get rid of all those edges and undermine the dermis from the subcutaneous tissue to reduce the tension on the suture line. Okay, so we're right here on the chin somewhere, and we've got a curve, and we got an area of the body that is constantly in movement. Try to put your hand here and talk and not feel movement of the skin here. On top of that, it doesn't hit the vermilion border, the nares or anything, but this is an area that's faces everybody, right? We want to prevent scarring. Okay, so it's going to take time. The wound is then approximated in layers. Ding, 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 layers. So we know we've got more than one type of suture that's going to be given to us. We're going to have that glycolic acid suture, and then we're going to have the we'll have absorbable and non-absorbable. So because we are approximating it, we're bringing it together in layers. With absorbable, ding, 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 absorbable sutures, meaning they're going to be left inside, right there, gives you complexity. Interrupted sutures, okay, so that means inside there, they're going to bring that together with individual sutures to bring it together, and a running subcuticular sutures. So they're going to bring everything together with absorbable sutures underneath, and they're going to use that running, just pull that tissue together on top again, so they don't have a bunch of holes with the sutures, and one line, one little piece sticking out, so that they can just pull that out, and we're not going to have as much of a scar. Okay, so this is complex written all over it. What are we going to do with coding it? Now, I want to let you know that I didn't double check these codes. I don't know when this was presented. So please, if the code has changed or anything has been a little bit different, we're doing this, going to be doing this for 2020, and so forgive us if the 13132 has any changes in it. Okay, so again, this was in the article that I wanted to share. And so we have a complex repair, forehead, cheek, chin, mouth, neck, axilla, genitalia, hand, and or feet. So the first thing we have to know is it's a complex repair. Where is it? Okay, it's on the face. It's on the chin, actually. And then size, 3.5 centimeters. This is 2.6 to 7.5. And then, of course, you got your E&M and so on and so forth. So this is complex. Right? Let's look at our next example. We have a 20 or 45-year-old treatment in the ER for multiple chainsaw injuries. Okay, this should be a no-brainer. We know what a chainsaw does to a person. Multiple chainsaw injuries, right? So someone's going to be hard pressed for this not to be a complex repair. Chainsaw should be your ding, 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 heads up, right? So we have a 5 centimeter laceration to the right thigh and a 2.5 centimeter lacerations to the forehead. Both wounds are typical of a chainsaw, meaning multiple serrated, full and partial thickness. You got a 0.5 centimeter flap defect perpendicular to the principal laceration axis. Yeah, so we're going all over the place. Due to the unlikely vascular viability of the flap, what? They decide to widely excise. Ding, ding, ding. They're going to cut all that tissue because it's just going to die. It's been chewed up. Let's see. So to create a nice single linear closure on both the thigh and the forehead. The edges are mobilized with proper undermining, pulling all that stuff together to minimize tension on the wound, and are closed in layers, ding, ding, ding. So tension, ding, 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 layers, ding, 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 with simple and running techniques. All of that is, again, something that should be heads up that this is a complex. So again, they have got 2 codes because we have the one on the head and we have one on the thigh. Make sure you know that it's going to be complex, location, and then length. Okay, so we have both of those that tell us. Those are our ding, ding, dings. I like doing that. Okay, because I'm a keyword type person. Okay, 3. A 26-year-old construction worker. Well, what could happen to them? Struck with a large glass window pane and experiences a 12-centimeter jagged laceration on the mid-abdomen. Okay. The individual is hemodynamically stable. Yeah, 12-centimeter jagged laceration. And taken to the operating theater, which that sounds very British to me, for proper anesthesia and wound care. Yeah, this is not going to be something that's going to be easily sewn up. Let's see. So let's just jump to the keywords. No residual foreign body. So they had to go in and debride. You don't want to be sewing somebody up and have pieces of glass left in the wound. No involvement of the rectus sheath. Now, the rectus sheath is that your abdomen has a covering that keeps all of the organs inside. Okay, so like just think of it as a sheath, like a little sheet of tissue membrane that holds everything in place. If that's open, then your intestines fall out. Okay, and whatever else can slip out. But your intestines, especially your small intestines, are packed in really, really tight, and you leave a little opening and they will herniate and come out. But if you lacerate across the abdomen, they're just going to spill out like that. You're welcome for the sound effect. Okay, so again, the tendon sheath, the rectus sheath is okay. No enlargement of the wound or dissection is required. Good. So they didn't have to make the wound bigger to be able to close it. Sometimes they have to do that. Due to the length of the laceration and potential wound tension concerns, the laceration is closed in layers, ding, 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 and retention sutures are used. So layers, we got multiple layers. There you got complex. Also, the fact that the fact that we have a 12-centimeter, that's really quite large. So there we go with that measurement, height, width type thing. Think of that in your brain. So again, always with repairs, you got to pick if it's complex, simple, intermediate, or complex. What's the length and where's the body part that's being sutured? All right, guys, that wraps it up. Now, I wanted you to not forget to like and subscribe for whatever uh, media that you're watching us on YouTube, Facebook, LinkedIn. There's also now the ability on Facebook and YouTube to hit that little bell or whatever little icon to let you know whenever we're going to be live streaming. And you can turn that off anytime. But if remember, I told you in the beginning that these go up in our club for our members, and our students have access all the time. But if you're not a part of the CCO club or one of our students, you don't get access to this, but you are more than welcome. We like for you to visit us and get this content free, but it's going to shut down. Okay. So if you hit that little bell or whatever the little icon is, then you'll know whenever we're going to live stream. We do 3 or 4 live streams a week, depending what's going on. And we do student as well as CCO clubs, which is more of a broader content, as well as our CCO live that we do on Wednesday nights, which is fun and really casual. But we also have other events, our weekly, our monthly public webinar. So again, take time to like and subscribe, share with your friends. If you enjoyed this content, absolutely let everybody know. And also, um, we really don't do any advertising. So, it's word of mouth. That would be very beneficial to us if you would share these our YouTube and Facebook with your friends and let them know as well. Whatever comments though you put in, we'll definitely follow up. But CCO club members, they always get priority with us. We pop those questions out and answer them right away. So thank you for joining us, and I'll see you next time. Bye.